So today we're going to start a discussion on renal organ system, the urinary organ system for step 1, USMLE step 1. And this is quite an easy module, so we will try to finish it as soon as possible. This is going to be how I approach reading first aid, and this would give you an insight on how you should read first aid when it comes to your preparation. So this is just an informal session to give you an idea on how to approach reading this book. Because if you just go in blind, then it would be very difficult for you to understand what is important and what is not. And this is a very important book. If not for step 1, then for other steps, it is an important book. Right, so moving on. So we'll be discussing everything, embryology, anatomy, all these, mainly these subjects, because these are quite tedious to read and prepare by yourself. So maybe by watching this video, you will have a guide on how to approach these. So starting off with renal embryology. Renal embryology is quite simple and straightforward, but there's an order that you need to first of all understand. So there are three main structures that are involved in renal embryology and kidney embryology, if we could say specifically. So there are three main structures. There is the pronephros, there is the mesonephros, and then there is the metanephros. The metanephros is the permanent structure that is involved. So what happens is that pronephros is the first structure that is involved. So if they ask you what is the first structure that is involved in the kidney embryology, then that is the pronephros. It starts from the week 4 of development and then it degenerates. The mesonephros is present during the week 4 of development. So as this is degenerating, then the mesonephros starts to work, and it functions as an interim kidney for the first trimester, and it persists in the male genital system as a Wolffian duct, right, forming the ductus deferens and the epididymis. So the mesonephros is something that persists in the fetus, even if it is getting mature, right? So mesonephros, as you can see, this is a pronephros, this is a pronephros, and this is the mesonephros, and this is the metanephros, right? So metanephros is a permanent kidney. The mesonephros is forming a duct, which is also known as the Wolffian duct. It is for male structures, so you need to keep that in mind, right? So this is the permanent metanephros and goes to week 4. It appears in the week 5 development, and nephrogenesis is normally completed by week 36. Now, these timings are not really important to memorize, but the order is important that you must understand. So, the metanephros is basically composed of two structures. So, as you can see, there are two structures in the metanephros. The one is the metanephric mesenchyme, and the other is the uteric bud. Right. So, the uteric bud, which is also known as the metanephric diverticulum, is fully canalized by week 10 of development, derived from the mesonephric duct to form the ureterus, pelvis, calyces, and collecting duct. So this is the important information that you must keep in mind, that there is a mesonephric mesenchyme, metanephric mesenchyme, and then there is a metanephric diverticulum, right? Now the uteric bud is also known as the metanephric diverticulum, right? And the metanephric mesenchyme is also known as the metanephric blastema. So these are different names of the one and the same thing. All of this structure together, it is known as the, let's connect it over here, it is known as the metanephros. So it is consistent of two main structures, which is the ureteric bud or the metanephric diverticulum and the metanephric mesenchyme or the metanephric blastema. So these are the two structures that it consists of. Now you must know that what these structures go and form. So the ureteric bud or the metanephric diverticulum forms the ureters, pelvises, calyces, and the collecting ducts. And the metanephric blastema, it forms the glomerulus and the distal convoluted tubule. So that's what it forms. So try to visualize this as the kidney. So if I could roughly draw a picture. So let's say, for example, that this is the kidney's rough diagram, right? So this is the proximal tubule, this is the descending limb, this is the ascending limb, this is the distal convoluted tubule, and this is the collecting duct, right? So this is a very rough diagram, but you are getting the point. So try to understand. So what is happening uh, is basically the structure which is proximal. Basically, this part which is proximal is formed by the mesenchyme, the metanephric mesenchyme, right? And the part after this, because many nephrons together will form, you may call as a, which should form as a whole network of nephrogenesis of nephrons. The part after this is developed by another structure. So this part, this complete part, or if I may refine it a bit, not the complete part, the part from the glomerulus to the distal convoluted tubule is formed by the metanephric mesenchyme. But the part after, including the collecting duct, so including the collecting duct, the part after this is formed by the metanephric diverticulum, right? So ureters, pelvises, calyces, and the collecting duct is formed by the metanephric bud, and before this is formed by the metanephric mesenchyme. So you may imagine that the glomerulus is starting from here, and this is going towards the collecting tubule, right? So just keep a picture of a kidney, of a nephron in your mind, and then keep this picture. Keep this picture, and you can see that because this is leading to the urogenital sinus, which is going to form the bladder in the future. So you can just imagine that the structure that is coming before, which is the metanephric mesenchyme, will form the structure that are coming before, such as the glomerulus, and leading to glomerulus leading towards the distal convoluted tubule, and the structure that is coming afterwards, that is going towards the bladder, would form the structures such as collecting duct and pelvises and calyces. This is how you must how this is an easy way to remember, right? This is an easy way for you to remember that which structures form what. So you don't need to memorize this. Just put a picture in your brain that the structure that is coming before, such as the metanephric mesenchyme, forms the structure that come first, as glomerulus and the loop of Henle and distal convoluted tubule, and the ureteric bud, which is the metanephric diverticulum, is going towards the bladder, so it will form structures that are nearest to the bladder, such as the collecting duct and the ureters and the pelvises and the calyces. So that is how you may remember. So so the far structure forms the first structure forms the first part, the second structure forms the second part. So this is how you're going to remember. So let me clean these things. Now they say that the aberrant interaction between these two tissues may result in several congenital malformations of the kidney. Renal agenesis, multicystic dysplastic kidney. So you must understand that any abnormality in the formation of the kidney is due to the aberrant interaction between these two tissues. So if they put up a general question on, let's say they put up a question in your paper about, they may quote it as a general question that there's a boy that has a congenital malformation of a kidney, and the doctor has to explain it to the parents on the reason why this has occurred, and they will give you many options for that. So, what could be the reason? And they would give you options such as, infectious cause, genetic cause, malnutrition, anything they could give you. And one of those options could be aberrant interaction between two congenital tissues. This could be the option. So you must remember that the basic reason why there is a congenital malformation of the kidney is due to the fact that there was an aberrant interaction between the metanephric mesenchyme and the ureteric bud, or the metanephric diverticulum, whatever you may want to call. So you must remember this point. It's important. Ureteropelvic junction is the last part of the ureter to canalize. So this is an important point. If it doesn't fully canalize, there would be congenital obstruction, of course, and can be unilateral or bilateral. Most common pathologic cause of prenatal hydronephrosis is detected by ultrasound. Obviously, any problem with the genitourinary system uh, is detected by ultrasound. Prenatally, of course. Any problem prenatally is detected by ultrasound. Any structural problem in the fetus is always detected by the prenatal ultrasound. You will not use any other imaging modality, because other imaging modalities such as CT scans and all of that are harmful for the mother and the fetus. They have radiation. So you will always use an ultrasound. So there is nothing special about this point. But this point is special that the most common pathological cause of prenatal hydronephrosis is uh, failure to to the failure of uretero-pelvic junction to canalize. So that is the most common pathological cause of the prenatal hydronephrosis. And the uteropelvic junction, I think, is somewhere over here. It's not really developed in the fetus. So as development continues, it becomes more pronounced, right? Uteropelvic junction is also a point of obstruction in fully developed children and adults also. So it is a point of constriction. We will look at that once we move forward to that section. So this was it for the kidney embryology, right? So you just need to remember these few points that I've explained to you. Potter sequence is a pathology. Potter sequence is basically a sequence of oligohydramnios. This is the starting point. So this is the starting point. This is the starting point, right? This is where the sequence starts. So oligohydramnios occurs and it causes compression of the developing fetus. So the fetus has less amniotic fluid around it. The amniotic fluid, one function of amniotic fluid is to cushion the fetus from the surrounding structures. So if there is less amniotic fluid, then of course there would be less cushioning of the fetus from the surrounding structures. So what happens is that the fetus gets compressed as the size of the fetus increases. Of course, the fetus starts to push around the surrounding structures. So when it starts pushing the surrounding structures, of course, they are fixed. So they start to exert a pressure. So if I could explain, so let's say, for example, this is the fetus, right, and this is the amnion, and these are the surrounding structures. So these are the surrounding structures, right? The uterus or whatever. So when the size of the fetus grows, the fetus starts to push these structures, and these structures would again push the fetus. So again, this resulting in a sort of a compression of the fetus. The fluid in between that is present over here is supposed to cushion the fetus. So it is supposed to neutralize this force that is being exerted from the fetus and from the surrounding tissues. Due to there being an absence or there being a deficiency of amniotic fluid, the compression is not neutralized. which results in limb deformities and facial abnormalities. What abnormalities can occur? Low sight ears, retrognathia, which is the retro version. It is basically underdevelopment of the jaw, flattened nose. There could be compression of the chest and lack of amniotic fluid aspirations into the lungs, which could result in pulmonary hypoplasia, which is, I think, the most fatal complication. So, starts from oligohydramnios, ends with pulmonary hypoplasia, and you have to remember that pulmonary hypoplasia occurs in this. So, this sequence is mostly important for the fact that it causes pulmonary hypoplasia. It's very easy. If you know that amniotic fluid, the baby makes amniotic fluid, it basically pees out the amniotic fluid from its urinary system, right? And then it swallows it. So once it swallows the amniotic fluid, what happens is that the fluid goes into the lungs and it causes the development of the lungs. It gives the body a stimulus to develop the lungs. If the fetus is not swallowing amniotic fluid, then the lungs will not get developed. They will not have any reason to develop. They will not be getting a constant stimulus to develop. So it causes pulmonary hypoplasia. Now, what are the reasons for oligohydramnios? It is caused by chronic placental insufficiency or reduced fetal urine output. May be caused by chronic placental insufficiency or reduced fetal urine output, including autosomal recessive polycystic kidney disease, obstructive uropathy, and bilateral renal agenesis. So, as I've said, that the baby pees out the amniotic fluid, right? And so babies that cannot pee, for example, they don't have a kidney, they have some sort of an obstruction, or they have some sort of a problem with the kidney. They have a kidney, but they have a problem with the kidney. So these three would be the causes. So they've described all three of them. Or the problem is not in the kidney. The problem is in the nourishment of the child, which means that if the child is not getting adequate placental nourishment, then of course the body will not be functioning properly. So the child is not getting proper nourishment from the placental, not getting proper placental nourishment. Then of course the body will not be. So if you just let me give you an example. So if you're drinking less water, you're going to form less urine. You're going to pee less urine, right? So that's the case. So if the baby is not getting proper nourishment from the placenta, he would not be producing adequate urine, and that would lead to oligohydramnios. Or if there is a problem in the genitourinary section. So these two are the reasons, two basic reasons, right? One is the nourishment, or one is the problem in the GU system, genitourinary system, right? They've given you a few examples, and if you want, it's important that you memorize these three examples at least. Uh, Potter sequence in itself is a mnemonic. Pulmonary hypoplasia, oligohydramnios, which is the trigger. The trigger is oligohydramnios, right? You must remember this. Twisted face, twisted skin, extremity defects, and renal failure, which occurs in utero. So this is the pathology of Potter sequence. I hope this is clear now. It's quite easy. Moving on, another pathology associated with the embryology of the renal system is horseshoe kidney. So what happens is that the inferior poles of both kidneys fuse abnormally, right? So you can see that this picture, the inferior poles are fused. As they ascend from pelvis during fetal development, horseshoe kidneys get trapped under the inferior mesenteric artery. This is again important. What structure do they get trapped under is the inferior mesenteric artery. What poles are fused are the inferior poles that are fused. They remain low in the abdomen. Of course, if the mesenteric artery, which is shown here, is blocking their ascent, they will obviously remain at that place. They cannot lacerate the artery and go forward. Kidneys can function normally but are associated with hydronephrosis, renal stones, infections, increased risk of renal cancer. Higher incidence in chromosomal aneuploidy. So Turner syndrome is most important here. It's like the most common, but it can occur in Patau syndrome, in Edwards syndrome, and in Down syndrome as well. So don't rule anything out, but Turner syndrome is the most common, and the second most common being, forgive me for this. So Turner syndrome is the most common, and second most common being Padau syndrome, and then Edward, and then Down syndrome. Something to notice here is why is the horseshoe kidney causing hydronephrosis? Why is it causing hydronephrosis? That's something to understand. What is the reason? The reason why, what they have mentioned is the ureteropelvic junction obstruction, and that is fine to a certain extent. But something that I also encountered when I was preparing is that because the kidneys are normally fused in the lower pole. So if I could show you, if you could see this picture, so concentrate on this picture. So because the kidneys are normally fused in the lower pole, what happens is that some of their urinary tract is also fused. And what happens is that because some of the urine passes on to this kidney and some of the urine passes on of this kidney passes on to this kidney, so this occurs. The reason what happens is that there is lack of regulation of the amount of urine that is being formed. So there is probably a lot of urine being formed which is being shared by both of these kidneys, and that results in hydronephrosis. This is one aspect of this that I encountered during my preparation, because this can help you remember, right? So these are both kidneys and they are fused inferiorly. So the urinary tract is also somehow connected in some cases. And there is lack of regulation of the amount of urine being produced. So a lot of urine gets produced, and then it, of course, uh, gets accumulated there, causing hydronephrosis. That's what happens. Renal stones infections are also there's somewhat of a related. They have a related mechanism, because of course, if there is more amount of urine getting produced and being accumulated around the kidney, then there is higher chance of renal stones. Then there is higher chance of infection. Then of course there is higher chance of renal cancer, and renal cancer chance always increases in any anatomic abnormality. So you must know that. This is a CT scan showing horseshoe kidney. So you must remember this. This is a horseshoe kidney, right? You need to remember this. This is very important. Just remember this image. This might come in your exam. Congenital solitary functioning kidney. The condition of being born with only one functioning kidney. The majority asymptomatic with compensatory hypertrophy of the contralateral kidney. But anomalies in the contralateral kidney are common, often diagnosed prenatally via ultrasound. Bilateral agenesis leads to Porter sequence. So I think this is self-explanatory. The person is born with only one functioning kidney. It's not really something that is high yield. Unilateral renal agenesis is when the ureteric bud fails to develop and induce differentiation of the metanephric mesenchyme. So there is complete absence of the kidney and the ureter. Now, we've discussed that there are two structures involved in the development of the kidney, right? There is the, if I could just clear everything from here so you can understand. So there are two structures involved in the development. So one is the ureteric bud, the other is a metanephric mesenchyme. If the ureteric bud is not developed, the whole kidney is not going to develop. And you might ask this question, why? So why is because everything in embryology is related to signaling, right? So the connection between the ureteric bud and the metanephric mesenchyme is due to signaling. So if one of the parts is not formed, this part will not induce signaling in the other part. It is very important that when two parts in our body are together, each of them they induce signaling on one another. There are some chemical compounds that are released and they tell the other part that we are supposed to form a connection. When one part does not develop, those set of chemicals are not formed, so the signaling does not occur. So metanephric mesenchyme receives no signaling in the absence of ureteric bud, and of course when it receives no signaling, it obviously has no clue what to do. So if any of these structures is not, one of these structures is not there, the other structure will not develop, resulting in complete absence of the kidney. So what is the reason for renal agenesis? The ureteric bud most commonly fails to develop. The ureteric bud most commonly fails to develop, and that results in the complete absence of the kidney because there is no signaling for the metanephric mesenchyme to induce the formation, to induce the connection. This is important to remember. I am unable to draw, apparently. This is a star, guys. Shows that this is important. Multicystic dysplastic kidney is ureteric blood develops but fails to induce this differentiation of metanephric mesenchyme. So there is a non-functional kidney consisting of cyst and connective tissue, predominantly non-hereditary and usually urinary. So the problem is the same. Uh, there is lack of differentiation and signaling towards the metanephric mesenchyme, but in this uh, scenario, the ureteric bud is actually developing, whereas in this scenario it was absent. So in this scenario it is actually developing, and in this scenario it was absent. That is a difference. If there is ureteric bud and there is no differentiation of metanephric mesenchyme, it is going to result in cystic dysplastic kidney. Now, the duplex collecting system is the bifurcation of ureteric bud before it enters the metanephric blastema creates a Y-shaped, bifibbed ureter. Duplex collecting system can alternatively occur through two ureteric buds reaching and interacting with metanephric uh, blastema. So what happens is that we discussed that this is the mesenchyme, this is the diverticulum. What happens is instead of one ureteric bud entering, what happens is that there is a division, right? And this is strongly associated with vesicular reflux or ureteral obstruction. Of course, if there are two ureteric buds, then there would be two collecting tubules, and then there would be a anatomical abnormality occurring. So two collecting tubules, two calyces. So this is going to result in UTIs, and of course there is more production of urine. So if there is two collecting tubules, one is there, and you attach two with that section. So now there is going to be more production of the urine, and there will be vesicular reflux and then ureteral obstruction in these patients. Also, of course, there is more production of urine, so it is related to hydronephrosis. Posterior urethral valves, probably one of the most high yield pathologies. The membrane remnant in the posterior urethra in males, so this occurs exclusively in males. Its presence can lead to urethral obstruction. It is diagnosed prenatally by bilateral hydronephrosis and dilated or thick walled bladder. So this is present prenatally. This is not a postnatal condition. This can be present prenatally and also can be discovered postnatally. Severe obstruction in fetus associated with oligohydramnios, of course, we studied that earlier. So the most common cause of bladder outlet obstruction in male infants is posterior urethral valves. This you need to keep in mind. This is very important. This is what they have showed us, that because there is an obstruction at the level of the urethra, there is just basically, this is the urethra, right? So there is just a thin flap of membrane that is remaining, which basically blocks the urine pathway. So as you can see, it is causing hydronephrosis and everything. So this is very important to remember. This is going to be exclusively in males. Vesicular reflux, not reflex, reflux. It's a retrograde flow of urine from bladder towards the upper urinary tract. It can be primary due to abnormal insufficient extraction of the ureter, or secondary due to abnormally high bladder pressure resulting in retrograde urine flow via the ureterovesical junction. Increased risk of UTI. So whenever there is a retrograde flow of urine, there is obviously going to be increased risk of UTI. So this is what you have to remember. This is very important. But this can be due to two problems. First is the abnormality of the insertion of the ureter, the way that the ureter is getting inserted, right? So if the ureter is getting inserted, I guess in 90 degrees, this is the bladder. The ureter is getting inserted here. So whenever the bladder pushes itself or contracts, some of the urine will go back. If I could draw, so this is the ureter, this is the bladder. Whenever the bladder contracts, some of the urine will go back. That will cause the problem. Or it is secondary to abnormally high bladder pressure. So if the connection of the ureter is perfect, but the bladder is contracting very strongly, right? Some high contraction is occurring. Then of course urine will go, even if the ureter is attached normally. So these are the two problems. One is the attachment of the ureter, and the other is the abnormally high pressure of the bladder contraction. And this is going to lead to recurrent UTIs. So if a neonate, if an infant is getting recurrent UTIs, if she is female, mostly they mention female in the questions, because for males for males they really ask posterior urethral valves, but if there is a female patient with recurrent UTIs, then you must be looking out for zygouterine reflux. Any abnormality in the attachment of the ureter or any abnormality in the contraction of the bladder. You have to look at that. So this is right for the embryology section. So we were just finished with the embryology section. Now we're looking towards the anatomy section, which is quite short. As you can see, this is the anatomy that we have. So the renal anatomy in itself is also quite short. It's not the fact that they have given us less material to study from, but the renal anatomy in itself is quite short. So the important part is written here, and as much as you are required to know for your competitive exams, it is written here. So left renal vein receives two additional veins, the left suprarenal and the left gonadal veins. And this is important, the part that it receives the left gonadal vein, that's important, because the obstruction from this can lead to varicocele, right? But this you would study in your reproductive module. So you must know that the left renal vein receives the left gonadal vein and the left suprarenal vein. This is important. This is an important caveat which you must remember. Renal medulla receives significantly less blood flow than the renal cortex. This makes medulla very sensitive to hypoxia and vulnerable to ischemic damage. So when there's going to be hypoxia or there's going to be decrease in the blood supply of the kidney, the most effect the biggest effect is going to happen in the renal medulla. And they're given an example of acute tubular necrosis. When this occurs, the medulla gets damaged. So they can ask you a question of which structure is most vulnerable to damage. They can give you a scenario of a patient that is going into a condition of shock, and then they can ask you that which part of the kidney is most vulnerable in this patient, and the answer would be renal medulla or anything related to it. Okay, you must keep that in mind that they don't really ask straightforward questions. The answer is most probably very straightforward, but the questions they're going to ask are going to be a bit convoluted. The left kidney is taken during a living donor transplantation because it has a longer renal vein. Because it is on the left side, there is no picture here, but because it is on the left side and the IVC, so let's say this is the IVC, and in red this is the aorta, right? So this is the aorta and this is the IVC, the inferior vena cava, and this is the right side. So that is why the the left vein is longer, because it has to cross the aorta. The right vein is shorter because it doesn't have to cross the aorta. So that is why this This is why the left kidney is taken during transplantation. All right. Glomerular anatomy glomerular anatomy. Excuse me, is quite straightforward. What you need to understand is that there is a glomerular filtration barrier, which is consistent of the podocytes, which is the innermost layer, the basement membrane, which is the middle layer, and the fenestrated capillary, which is the outermost layer. So the capillary is comes first. Then there's of course the basement layer, and then there's the podocyte layer that comes. So these are the three layers that you must know. Outer one is the capillary, the most inner one is the podocytes, and the middle one is the basement membrane. You must also know that the juxtaglomerular cells are a part of the afferent arteriole. They are a part of the afferent tunica media of the afferent arteriole. So that is what you need to know. And the macula densa is the part of the distal convoluted tubule, as you can see. So juxtaglomerular is a part of the afferent arteriole, and the macula densa is the part of the distal convoluted tubule. Most students don't seem to know the difference. Okay, and this is the afferent arteriole. Between these are the mesangial cells, and these are mostly affected in the IgA nephropathy, which you will study in a bit in the pathology section. So that is what is happening. And so this was a discussion of the glomerular anatomy. Now, looking forward to the course of the ureters. So this is mostly an image-based question, right? This is mostly an image-based question, and there are four constrictions. You can see the four arrows, which may not be clear from this picture over here, but there are basically four constrictions that you must know about, and they are uh, uretero-pelvic junction, the pelvic inlet, and the uretrovesical junction. So this is the part where the ureter enters the bladder. This is the part where this part is where the ureter exits the kidney, and this pelvic inlet is the part, of course, in which the pelvis enters the kidney, right? So there are three common points of ureteral obstruction, not four, but three common points. Okay, something that is mostly important as well is the course of ureter is that it travels over the iliac artery and under the uterine artery and vas deferens. So there's a mnemonic over it nowhere that the water flows over the iliacs and under the bridge. So by bridge, they're calling either uterine artery in females or vas deferens in males, or and they're saying that the ureters flow over the iliacs and they flow under the uterine artery or vas deferens. So these structures can be damaged during any surgery of the ureter, or the ureter can be damaged during any surgery of the uterine artery or the vas deferens or the iliacs. Ureter is most commonly damaged in abdominal hysterectomy also. Abdominal hysterectomy. I hope you know what hysterectomy is. Hysterectomy is when we are taking out the uterus of the patient. That's what hysterectomy is basically. So ureters are most commonly damaged. Iatrogenic etiology of ureteral damage is hysterectomy. You must know that. And over here, they've also mentioned that gynecological procedures such as ligation of the uterine or ovarian vessels may damage the ureteral obstruction. So hysterectomy is also a part of this. So artery ligation or hysterectomy can damage the ureters, cause the leak, right? So that's what they've mentioned over here. That water under the bridge, which means over here ureter is under the uterine artery in females, under the vas deferens in males, and that's basically it. Okay, and they've also mentioned the median umbilical ligament. So you're going to come across two different words. One is the median. Let me write it. And just like this, there's another which is known as medial. So allantois, or the urachus, gives rise to median, and umbilical artery gives rise to medial. All right, so median umbilical ligament is is a remnant of allantois. Allantois has an N in its spelling. So I hope you remember what allantois is. Allantois is a membrane in the fetus. So allantois uh, gives rise to the remnant of the median umbilical ligament. And umbilical artery is because it has an L in it, it gives rise to medial. Okay, so we have already completed the anatomy and embryo section from first aid for the urinary system. So now we're going to look at a few questions because just reading without practice has no use, right? So we're just going to look at a few questions now. And first one being, always read the question first, last line first, and then read the rest of the question. So a baby boy. So which of the following embryologic processes most likely failed in this child? A baby boy dies several hours after his birth, despite several attempts to save his life. He was born with wrinkled skin, deformed limbs, and abnormal facies. Prenatal ultrasonography at 15 weeks indicated that the mother's pregnancy was complicated by oligohydramnios. So, first of all, look for the clues in the question. So, oligohydramnios, and look at the presentation, the wrinkled skin, the deformed limbs, the abnormal facies, right? So, we said that there are three reasons for oligohydramnios, right? We studied there are three reasons. The first reason being placental insufficiency, the second reason being any obstruction in the pathway of urine, any urethral obstruction. This is a baby boy, then maybe urethral valves, posterior urethral valves. Now, both of these reasons are not in the options. So then, obviously, the one reason that is left is the third reason that we studied due to renal agenesis. So, renal agenesis is the reason for this patient's oligohydramnios. Now, which option uh, is signaling towards renal agenesis? Which option is signaling towards renal agenesis? So, I'll give you some time to think, pause the video, think about it, and I hope that now you have an answer. Option B is the process that if it fails to develop, the uteric buds fail to develop, then uh, there would be deficient formation of the kidney. There would be no formation of the kidney. So that is the answer. So this is the explanation for it. And you can of course read it, but the most important thing is that because the uteric bud is not formed, it does not signal the metanephric blastema, and then that is the reason why um, the kidney is not being formed. So that is what is written here, and you can read the rest of the explanation yourself. There's no problem in it, but I'm not going to spend too much time on this now. I'm just going to move forward, and you can read it. The bottom line is that the Porter's syndrome is characterized by bilateral renal agenesis. So yes, this was Porter's syndrome. I forgot to mention that this was Porter's syndrome. Uh, it's quite simple: wrinkled skin, deformed limbs, and abnormal facies is basically sort of a triad that you must remember for Porter's syndrome. So we discussed this embryology question, and I just wanted to show you guys the picture that we studied earlier. So this is from where you can answer this question. If you remember, I told you that everything really depends on the formation of the uteric bud. So if uteric bud forms, uh, it induces the differentiation in the metanephric mesenchyme, right? So if there is renal agenesis, then you can safely consider that the uteric bud is somehow not formed. or there is a problem in the formation of the ureteric bud. So you can safely say that this is the culprit, right? Anyways, moving forward, and this is where the reasons for oligohydramnias were present. So we've discussed that as well. Now for the next question, they're saying which of the following is the most likely diagnosis. So a 33-year-old professional basketball player is brought to the emergency department because of an intermittent and excruciating pain in the right flank that radiates to his inner thigh and testicle. The pain is accompanied by nausea, vomiting. Physical examination shows negative rebound tenderness. He has guarding and dysuria, hematuria, and the most important clue is that urine crystals are envelope and dumbbell shaped. So looking at this presentation, a pain that is intermittent and that is traveling from the right flank to the inner thigh and testicle, along with nausea, vomiting, and urine crystals are also seen. So they basically handed you the diagnosis, right? And this is the kidney stone. So from loin to groin is the name of the basically what they call this presentation. So loin to groin signifies the presence of the kidney stone, right? Now there are two options for kidney stones. So what should be the option? So now you basically have to know that what is the looking at the shape, which kind of the stone this is. Now we of course haven't studied that yet, but I'm going to tell you that dumbbell shaped is always calcium phosphate stones. So you have to keep this in mind. They're always calcium phosphate. So I would go for radio opaque kidney stones. These are urea stones, and urea stones are not dumbbell shaped. They are irregular shaped or spiculated. But urea stones would also be in a patient of gout or in a patient that is undergoing chemotherapy or is a patient that has hyperuricemia of any kind. So the correct answer is D, and you can read this as well. All of this is very important. You can read this, but for now, I'm just going to skip it. You can pause the video here and read the explanation of these answers as well. So this is it. Uh, yep, uric acid stones are radiolucent, right? So if I could show you, now the urea stones are not given, so you can read this as well. This is important. Pause the video here and read it. But moving forward, cells from which structure secrete a substance in response to this hypotension volume depletion? A 44-year-old woman with adrenocortical insufficiency comes to the physician because of weakness, nausea, and vomiting. Her blood pressure is 90 by 60. Her lab studies show the following. So, serum osmolality 260, sodium 128, potassium 5.5, which is more, and bicarbonate 18, glucose 68. So basically, they're just asking that this patient has hypotension and volume depletion. So which structure releases a compound? And I already told you that the dextroglomerular apparatus, which releases the chemicals in regard to hypotension, is a part of afferent arteriole. So you must always remember this. You can also see that the JG apparatus is a part of the afferent arteriole, right? You can see the explanation here. And I guess now the MCQs are starting to deviate towards the physiology part. So we're just going to end them now and continue after we've studied the physiology and the different aspect of renal module.